How can you put that whole big implant through a 3-millimeter incision?
Because I use a plastic funnel. I've been using this since the early 1990, this plastic funnel to introduce these implants. These implants are like a Velcro and it's rigid, so they get adherent to the tissues. They fixate it with the self-drilling mini screws. And because it's a wraparound, you don't need a lot of screws to maintain the position.
Welcome to the Doc Moliver podcast. Plastic surgery, science, and cool stuff in between. So, Oscar, one of the earliest memories I have of you and some of your extremely innovative techniques was your minimally invasive endoscopic work in facial surgery. And one of the first things I saw was your subperiosteal lift. And there was a lot of controversy. There was a lot of back and forth. You know how when we go to the meetings, there's the way I do it versus the way you do it. So there was some people back then saying skin-only lift or a mass plication. Why don't you tell us your approach to facial aesthetic surgery and how you look at the face? Is it, in other words, is it deflated? Is it a structural problem? Is it a skin texture problem? And how you bring those things together to decide how you're going to approach a facial case to make it more aesthetically pleasing?
All the above. All the things you have mentioned needs to be addressed.
Of course.
And that has to be agreed upon the patient and yourself. And that's why I call it, I trademark this just for marketing purposes and for the patient to understand what I'm talking instead of talking subperiosteal endoscopic implants. It's difficult for the patient to understand those.
Right.
I call it custom design facelift. So it's not a facelift, it's a rejuvenation. I like more the term rejuvenation because it's not only lift. So let's start with the subperiosteal and why I do it and why is my preference. Basically, the subperiosteal is the elevation of the soft tissues on top of the bone. And as you know, this has been a very controversial initially. A lot of people, they do it now and they accept it, they like it. For me, it's the best way to address the face, and I will tell you why. One of the things that happen is whenever you do subperiosteal, you are moving the insertions of the muscles at the bony level. So when you lift it, and let's talk about the release of this and elevation of this. So now you change it, the position of the modiolus, change the tension on the upper lip, and whenever you included the periorbicular auricularis muscle, the periorbital auricularis, now also you are moving the corner of the angle of the eye. So you change the whole thing in an upward direction. And for me, this gives whatever is called the rejuvenation of the facial expression. No other procedure does that except Botox. With Botox, you can modify the expression of the patient because you're working on the muscle, you're addressing the muscle and the key areas to improve the function of the muscle in a more positive way to change the expression of the patient. Unfortunately, the Botox is only temporary if you want to do it every 4 months, because you need to do it every 4 months. The Botox might last 6 months, but doesn't last 100% 6 months. So you need to do it every 3-4 months to maintain it and give that expression that you're looking for. Obviously, you have to go to a well-trained surgeon, plastic surgeon, or good dermatologist who understand well the aesthetics of the face and the muscles. Because now everybody's doing Botox, and you see this sometimes weird expression on patients, So the very more aggressive deep surgery, that's a more permanent solution to the tire sad expression or the Botox. Although the Botox is not complete, like you can do it with the subperiosteal. I think for me, this is the major benefit of the subperiosteal lifting. You can see here on my early open subperiosteal, the changes in the facial expression of the patient. The patient looks like she's smiling. It's not. It's just in repose. In every publication I have it. Just look at it, the expression of my patients. I'm not asking them to. They have come for pictures. They have sometimes the nurse takes it, or the patient themselves, they send the pictures. That's the way they are, because it's logic. You have lifted the malleolus, the corner of the mouth. You have changed the position of the eyelid raphe. And these are expressions of happiness. Well, I taught this for many years in Baltimore, doing workshops on facial rejuvenation, initially the open approach. And then actually, then I went into the endoscopic, because for me, the subperiosteal approach was the most suited for the endoscopic techniques on the face. This is one of the early publications, 1994. So you can see some changes in the volume, because you can lift the cheeks, you can lift the corner of the mouth, the periocular orbicularis, and now with the elevation of the V-shapes and the SUV, you can create the OG or the mid-face. That's, for me, is the best for that. So this is the first patient I did pure endoscopic, the whole face, forehead, mid-face, and neck. No skin removal. And this patient has been, I saw her for 25 years. And she didn't need any additional surgery. She still looked good. So this is 2 years later. You can see this is done in 1993, I believe. This is the first patient with full, total facial endoscopic surgery without the skin removal. So now, my concept is more for the patients moving into whatever I call it, custom design facelift. So I customize the surgery for the patient's need. So this is a patient who wants forehead and mid-face. So I did it endoscopic forehead and mid-face, and no skin removal.
So look, I'm that guy, right? So we're always cautious about that facelift, in particular that brow lift for the guy that's got no hair up here. One of these days, you're gonna look like me too, Oscar. When you get older, like me. So where are your incisions here? Can you show me?
Traditionally, we were taught that the baldness is a contraindication for any lift, including the subperiosteal endoscopic forehead lift. If you put the incision in the glabrous portion of the here, maybe it's here, maybe it's here.
So it's there, but it blends after a while. And you're not making a long incision across the forehead. You're making a 2 centimeter or 1 centimeter incision.
Yes, tiny incisions, and the other one is in the temple. So the other one is in the temple. So you here, and so you don't see it. The other one is here. If you're careful in closing and protecting during the surgery, those incisions you won't see it. Plus, also it's along the Langer's line. So you're not crossing the Langer's line.
Of course.
And you close it in layers, in 2 layers, to prevent depression. Because sometimes you don't see the scar, but you see the depression.
Sure.
So that's how I approach these patients. So there's no contraindication.
So for other plastic surgeons out there, there are endoscopic brow lifts, and then there are endoscopic brow lifts. Why don't you go a little bit more in detail? Is this a total subperiosteal, and are you releasing the periosteum along the orbital rim like we've been taught to?
The key of the brow lift is to release the periosteum just above the arcus marginalis. And my first generation, when I explained that, even when I was doing the open approach, was to undo the release at the arcus marginalis, just in the border of the bone. But the problem is, if you do that, you might skeletonize too much here. So I go a little bit higher, the arcus marginalis, which will be probably about the halfway of the brow.
Mm-hmm.
Okay, so this is number one. And second, the sequence of dissection changes. So now I do first the dissection, and I do the muscle modification. I remove the corrugators and release the procerus. And then after I have finished that, when I'm ready to close, I release the lateral periosteum above the arcus marginalis. And this is one specific reason for that, is because if you release the arcus marginalis completely, your nerves are going to be under tension constantly during the manipulation, during your surgery. You're pulling, you're stretching, and then you have a high rate of neuropraxia of the forehead. A lot of numbness, a lot of tingling, and you stretch too much the nerves, and it takes a long time to recover. And when they recover, they give you all this weird sensation.
Yeah, I've heard that. I've heard that complaint from patients, and that's a good reason, or a reason why a lot of people have stopped doing this. They don't do those little refinements that you talk about.
So that the way when I'm keeping the lateral periosteum here, I'm not putting a lot of tension on those nerves. And then I release it when I'm going to close, I put it drains, and that's it. So that's one of the variations I do. And then I do subdermal fat grafting. So I inject fat to the brow and also to the lines to improve that. I can see here, because this, whenever you do the corrugator resection and even the procerus, you're going to have depressions here. And they become indented. You can see the borders.
I've seen that.
Of those of your resection. So I do a subdermal fat grafting. In every level that you can find tissue, you can inject your fat. And so that improves the volume and also prevents all the irregularities that you see after the end of forehead. Also, if you have deep lines, I put it subdermal fat grafting, usually the nanograft, or I call it the picograft, which is even much smaller, obtained with a laser. That's another topic. So here you can see the beautification of the periorbita. This beautiful girl, you can see how enhances her eye appearance only with end of forehead and fat grafting. So I put a fat grafting all the time that I do end of forehead. So again here, end of forehead, mid face. This is a beautification. This is not rejuvenation. The patient is not old. So these young patients, when they come, if you call it rejuvenation or lifting, it's a negative connotation for a young ladies and young patients. So I call it rejuvenation. So you're basically remodeling the facial structure, improving the OG to the right position to make it more sophisticated, more appealing, more beautiful, happier. So this is a sophisticated look that you get with this rejuvenation. So the patient had an end of forehead and end of mid face. And this is another patient, again, end of forehead, end of mid face, and fat grafting. You can see the changes in the volume. So she needed, in addition, she needed fat grafting because she doesn't have enough volume to give that beautiful appearance to the cheek. So now she's more sophisticated, more beautiful, and happier. So that's end of forehead, end of mid face. 4 incisions in the forehead, 1 incision intraorally. So I do it the intraoral incision for the mid face. You have more control, and you can do a lot of things intraorally, including the release of the Bichet's fat pad that can produce the better OG on the face. So this is another custom-made, different type of surgery. She didn't have any end of forehead, no end of mid-face. She had an extended cervicofacial lift with, I call it temporal shift. Because the problem is when you come here and you do the lift, you're going to have bunching of the skin here.
Right.
So through this incision, I do, through this incision here, because my cervicofacial lift ends in here. So I do subcutaneous dissection entirely on top of the temporal parietalis fascia. And advance this skin, this skin here in a vertical direction. Now I used to put a suspension sutures with stapler and suture. Now I use the Viterbo, not the hours wall, I'm sorry, the hours wall netting, the external suture, which I remove within 2-3 days.
So you are using that?
Yes, I'm using that very sparingly. I don't use it like Andre does it. I guess I don't need that much, but because they do it also for hemostasis. If you do a good hemostasis during your surgery and you control the blood pressure of the patient, probably don't need to do very aggressive netting for the neck or face. I do it in the retroauricular area when I do my close endoscopic neck lift without the skin removal. So I redrape the skin on the back with the netting. The same way I redrape this part of the skin on the temple with the netting. So now I correct this problem as well. So my dissection goes all the way to here. So these require a deep neck lift. The patient has a salivary gland, obviously fat. So I tense the gastric as well. So it's a planimetric repair of the deep layers of the neck. After you have done the partial removal of the salivary gland, the removal of the deep fat, then you can advance the digastric to the midline to close that space and also give a little more lateral tension. So that gives you a more uniform appearance. Also, I like, although she's not the perfect example, but I like more my necks in a C shape. I don't like this L shape, although most of the surgeons, they like this L shape.
So you're not using a GM Papa suspension suture across the neck?
I use it.
But you don't make it too tight. You make it a little bit looser?
No, I think the problem is too much removal of fat here, the skeletonization.
Right.
More than the suture. The suture doesn't, it's impossible for the suture itself to deepen this. So I don't like the right angle. I like more the S shape.
Much more natural, much more believable.
Yeah, that's more like a C. I don't like the angle. I think we have a little, aesthetically, little different view than Ellenbogen. The Ellenbogen likes this angle.
Right.
More like a C. And I think it's a more natural, look more beautiful in my view. So you can see here, this patient had a salivary gland enlargement. And, a lot of people, they say, and I've been doing this since the early 90s. Maybe even my early case, it was the late 80s when I started doing my first removal. And I think it was Pina from Brazil, one of the first that published about the salivary gland section. Nobody gives him credit for this, but Pompeo Pina, I believe, his first name is Pompeo Pina in Brazil. So I started doing this, and when I remember one time I presented a video on this on my results on one of the meetings in New York with Cheryl Aston. Everybody was almost killing me and said, why you had to do that aggressive neck surgery? But you need it in many patients. Otherwise, you don't give a good result. It's not for everybody. Not every plastic surgeon can do that. You need to have a lot of knowledge of the deep anatomy, good instrumentation, and patience. It sometimes takes a little time. You cannot rush to do this because you need to do a totally deep, good hemostasis. So anyway, so you remove partially the salivary gland and the deep fat, and then you do the redraping of the skin after you do that.
So you're not repositioning it. You're taking fat from Bichette, processing it, and re-injecting it subcutaneously. No.
But deep. I believe because the effect is transmitted. I guess there's something probably we need to study. I don't know. But I guess when you remove it and put it, stimulates, and it's the area is a raw area of dissection, so probably ready to be
absorbed.
All the factors stimulate the stem cell from the shape. It's different that if I don't do that. For some reason, it's not only the volume, it's more than that. You see the quality of that. Also, this patient quality of skin also has improved because I put a superficial fat. You see the lines on the glabella has gone. So I put a subdermal, a lot of subdermal fat in the face, in the nasolabial, in the glabella, on the brow.
I love it. I love it. I think your result here is phenomenal. And I also add subdermal nanofat or fractofat, call it what you will. And, it just improves the quality of skin remarkably.
And then I use in every level, depending where you need. So I had to customize. That's why I call it custom made, custom design facial rejuvenation. So this patient had a endo forehead, endo mid face. And one of the things about the shades, the repositioning, not only produce the concavity here, you also reciprocally, you enhance the convexity. So with one maneuver, you are doing both, enhancing the convexity and creating the concavity of the OG of the mid-face. That's one of the reasons why probably I don't use much of implants on the cheek. I prefer the V-shape. The V-shape is great. And I don't sacrifice it. I use it. You can see the changes in the modiolus position. And the patient had a small vertical and anterior projection of the bony chin. So I put a geniomandibular implant, which is a new modification, new design. It's a wraparound implant that improves the vertical dimension of the mandible.
Yes. Yes.
So that gives more balance. And then now I have a better platform for my neck. Then I can do whatever I needed with a deep cervicoplasty. Most of the patients, they need deep cervicoplasty. Even young patients, I see it. They come and say, doctor, do a liposuction of the neck. So I pinch the skin and said, you don't have fat. Everything is deep. So, and you can do now with the ultrasound, you can check it and see how much superficial and deep fat the patient has. And most of these patients, they have deep fat. So, and this lady, everything is deep. This is deep fat. There's no superficial fat. Very little. So actually, I don't like to remove superficial fat unless it's too abundant. Because the more you do with aggressive liposuction on everywhere, especially on the neck, you damage the skin. The skin needs good amount of fat because the fatty acids helps to from the subcutaneous layer helps to produce collagen. So those are needed for collagen production. So not only is mechanically you thin down and produce irregularities if you do too much liposuction or superficial fat removal, is the collagen, the quality of the skin is diminished. That's why thin patients, they age terribly because they don't have enough fat. There's no good collagen. It's not only the exposure of the sun. Even if they are not exposed, they don't age as well as somebody who's heavier. So somebody who's heavier, they have better skin everywhere, not only in the belly, in the abdomen, and also in the face. So good amount of fat is needed for good quality of the skin. So I don't like to remove much of superficial fat. This is a patient, a friend of mine, former partner, who I did a custom design facelift. She already had a facelift before. And again, this is not deep. This is everything at the deep subcutaneous layer, no SMAS, deep subcutaneous layer and fat grafting. So everything was done fat grafting in different areas. I did forehead. and I did that to shorten this long forehead. So now she's and with a superficial fat, the nanograft with a rich stem cell obtained with the laser, the patient has a beautiful result. No implant either, because she doesn't need a lot. So in those cases, I use a structural deep fat on the bone below the masseter muscle. So the whole jawline and the chin was improved, enhanced with deep fat, and the superficial was improved with the nanograft.
How far post-op is that picture on the right?
Probably a year or more.
Very nice work. Very nice.
Yeah.
And did you redrape or take any skin out on her?
Yes. I did a secondary lift.
Okay.
Secondary lift. And I had another technique, which I haven't published yet, so I don't mention how to modify the facial expression with more superficial surgery. So that will be probably for future presentations. So.
Okay, we'll let you go. I wanted to know what it was, but we'll let you go this time.
Okay. This is some of the implants I have designed for the face. And the one I use the most is what I call the mandibular matrix, which is the chin and the angle, the geniomandibular and the angle implant.
What is that made out of?
It's a porous polyethylene made by Porex Medpor and by Poriferous company. I use it from Poriferous now. It's in Georgia. I don't get any royalties, so I could tell it freely.
And what's your approach to that? Is it intraoral or submandibular?
Submental. With a single 3 millimeter incision, everything is endoscopic dissection of the entire jawline, and I put it from there to the angle. So you can improve the whole jawline, and then based on that, you can do your deep neck, cervicofacial, etc. So you can give better result.
You're doing your whole endoscopic surgery through a 3 millimeter submental incision.
Yes.
And how are you placing the implant? Where is that incision?
The same incision.
How can you put that whole big implant through a 3 millimeter incision?
Because I use a plastic funnel. I've been using this since the early 1990, this plastic funnel to introduce these implants. Because these implants are like a Velcro and it's rigid. So they get adherent to the tissue. So you put this funnel, of plastic funnel, and then you can push your implant all the way there. And then you fixate it with the self-drilling mini screws. And because it's a wraparound, you don't need a lot of screws to maintain the position. Just in the key areas because they get wrap around the angle and the chin. So that was I was talking to you about the expression of the face. And one of the reasons why I emphasize this is because with aging, we became tired, we became sad looking. And you see the happier people are more appealing. They are more successful. They seems to have better personality and are accepted everywhere. When you see somebody with a sad face, kind of rejected. And a lot of the aging face becomes sad. And you don't know if they are sad because the tissues are making that look that way, or internally they're sad. So we cannot decode that faces. So it's important for us, whenever we do facelift, to give to the patient the right expression of rejuvenation expression, so you can be able to decode better feelings of those patients. So this is why I see the deep subperiosteal lifting changes the facial expression. And this is an old patient with the open lift that you can see the changes in the expression. She looks more beautiful. She looks more, she looks happier, rested.
Amazing, amazing technical detail. Thank you so much for being with us today and showing us some of your work and how it all evolved.
Thank you very much for the invitation, Clayton.
Thanks for visiting. See you next time.